the opportunity to speak to everyone today. Appreciate Terry and Mike, your help, and Brittany for helping getting this all squared away this morning. I just want to kind of give a surgeon's perspective on occupational medicine and kind of the shifting paradigm that we are all feeling as part of our practice as we engage not only from a multi-specialty group and from hospitals with employers, but our role in making sure that we can do this in a cost-effective and efficient manner. So objectives today, just learn about occupational medicine. This was some education for me, just to understand the scope of this, to quantify the impacts of work-related injuries, to understand the general surgeon's role in occupational medicine, which again, that's a paradigm that isn't really, a lot of surgeons aren't necessarily engaged in or specialists are engaged in, but we are very rapidly becoming aware of what our role is. And then just to rationalize this as a new era of employer engagement with healthcare entities and providers providers to optimize care comes about. I'll skip this as Mike has already done the introduction. I appreciate. I'm very humbled by that. So briefly, what is occupational medicine? The American Society of Occupational Environmental Medicine was actually founded in 1916. It became a fellowship-trained medical subspecialty about the mid-century. So the actual journal is Journal of Occupational and Environmental Medicine. It's a board specialty under preventative medicine and basically focuses on the diagnosis and treatment of work-related injuries and illnesses. It's actually found this interesting. It's actually ranked among the highest in physician satisfaction and lowest in professional burnout. So there's got to be a lot of job satisfaction with being able to help people with this. So wish I could say my specialty had the same rate of low burnout. Occupational medicine really focuses on a couple of things: clinical care, prevention, disability management, and then there's a strong focus on research and education, especially as it pertains to safety in the work environment. Occupational medicine obviously really started to take off in the mid to early 70s. The development of the Occupation Safety and Health Administration, passage of the Occupational Safety and Health Act. Goals were to improve safety, guarantee safe working conditions, and regardless of a job type. We'll go through some of the facts from that. It also developed the National Institutes of Occupational Safety and Health, which is actually a division of the Centers for Disease Control, which I actually didn't know about until I did a little research for this. So there's a lot of research that's undergoing constantly regarding this. And if you do a literature research with this, there's literally tens of thousands of papers that come out. It seems like just about every year regarding this. Some OSHA facts: there's 4,764 fatal work-related injuries in 2021. Interestingly, a 10.7% decrease from 2019. That equates to about 3.4 fatalities per 100,000 full-time employees. Employers reported 2.7 million injuries or illnesses in 2020. That was down 5.7% from 2019. Interestingly as well, and probably not all that surprising, injury cases actually declined during that 2020 reporting period, but illnesses more than quadrupled. And guess what happened in 2020? COVID. So we see a lot of that. OSHA facts again: how many work-related accidents happen every year? These numbers are pretty staggering to me. 12,900 estimated work injuries per day, 90,400 work injuries per year, and over 7 million per year. Most common non-fatal workplace injuries: sprains, tears, and strains. Pain and soreness, lacerations, and punctures rank amongst the highest. Among employed persons, 38% of injuries occurred at work. So obviously people can get hurt not at work, but they're on insurance. Among these, 40 men aged 50 to 64, 49% occurred at work. They obviously comprise a substantial part of the injury burden, those injuries at work, and account for more than half of all injuries in some age groups. Interesting as well, the occupations with the highest injury rates: janitors and cleaners, 120 per 10,000 full-time employees. registered nurses, which I was really surprised about, 105 per 10,000 full-time employees, and then retail sales is pretty high as well. Most dangerous injuries, not surprising, construction, experienced most workplace-related deaths, education and health services. I was surprised about this, but again, these are all facts off the OSHA website. Most non-fatal injuries involving days away from work, and then agriculture, forestry, hunting, fishing, highest death rates per 100,000 workers. So. According to the 2021 Liberty Mutual Workplace Safety Index, serious non-fatal workplace injuries accounted for $59 billion in direct costs to U.S. workers in 2018. That's more than $1 billion a week, which is it's a staggering number. Injuries again, work injury costs, $163 billion was estimated in 2020. It equates to about $1,100 per worker, 1,310,000 per death, and $44,000 per medically consulted injury. So this is a pretty staggering amount of money that's at stake. Time lost due to work-related injuries in 2020, 99 million days lost. Due to injuries just in 2020 was 65 million, and injuries from prior years that are kind of carryovers, which obviously this is kind of a problem. You have a debilitated or a patient with a disability that carries on. It carries on into years beyond as well, which is a huge cost to the system. Some sobering facts again, just not trying to belabor everything, but 69% of injuries and illnesses, according to the Committee on Education and Labor, are actually not ever reported. So these numbers, while they're staggering, are really probably underreported, and the true cost is much more than we realize. General surgery's involvement in occupational medicine. This is something that up until a couple years ago, I really didn't quite understand the role that I would be playing in occupational medicine. Obviously, we always have, workers' comp cases and things like that come through. But as we've engaged in employers, one of the biggest things that we've come to understand is that there is a huge role for specialties, whether it's medical or surgical specialties, in trying to make sure that employers who are more and more self-insured or have stake in this are able to engage multi-specialty groups, hospitals, to try and contain costs, because we all know this is not getting cheaper. Every year I see my own medical, expenses and cost of insurance go up. So we're all realistic. We know that we need to contain costs. We need to do this not only for ourselves, but also to retain employees and provide the best care possible. So from a general surgery standpoint, I just want to kind of give a little background on general surgery, because a lot of people don't necessarily understand this. It's a broad surgical specialty, basically encompassing gastrointestinal surgery, soft tissue injuries, wounds. We do a lot of hernias. There is some preventative medicine that's involved with this, with breast cancer screening, colonoscopies, endoscopy, and then a fair amount of our work is also done with oncology, and a variety of specialties, from thyroid disease through breast cancer, through GI malignancies and soft tissue tumors. So surgeries from a general surgery, I love general surgery from my perspective, because I'm not pigeonholed into doing just one surgery all the time. I think it's one of the biggest things that kind of drew me to general surgery as a specialty. I can be in any given day doing an endoscopy, and then take a melanoma off, and then do an open hernia repair, and then jump on a robot and do a more complex procedure. And I understand the value of all these different techniques and the way they're able to do these things. And each of them has value in what we have to offer patients. And certainly patient factors play a huge role in how we're able to intervene on their disease process. So we talk about general surgery. Open techniques is kind of the standard technique, where somebody has a big incision on their belly. And I'm sure we've all seen people, or have had people in our own families that have experienced, large surgeries, emergently or otherwise. Traditional laparoscopic techniques have been around since the late 80s, early 90s, and that's kind of the standard procedures for removing gallbladders and appendixes. And there was kind of a paradigm around the early 2000s, late 90s, early 2000s, where we were starting to kind of dabble with laparoscopic techniques in some other procedures that otherwise were traditionally open procedures, like inguinal hernias, incisional hernias, and just to kind of get a scope of how common incisional hernias are. After some of our big open surgeries, up to 30 to 40% of those patients can develop an incisional hernia after those major procedures. So everybody is looking at a technique. Well, how do we fix a hernia after a major procedure that minimizes the risk of them developing then another hernia as a result of a procedure and kind of perpetuates itself? So these laparoscopic techniques, right around when I was starting to train, were limited. They were very, very labor intensive, very, very challenging, where we would do an open inguinal hernia and it would take 45 minutes for us to do this with excellent results. All of a sudden, we went to a laparoscopic approach with limited technology and our limited ability to kind of manipulate tissue inside the abdomen. And that really created a conundrum where, hey, yeah, we can get a repair. There was a steep learning curve with it, but you could get there. But it really took, 3-4 hours to fix the same hernia as it did from us doing it open. There's obviously inherent risks with patients being under anesthesia that period of time. You certainly don't want to be at a surgeon's beginning of their learning curve when they're trying to start to do laparoscopic procedures like this. So there was a lot of factors that play into that, and a lot of people kind of steered away from doing a lot of the traditional laparoscopic techniques for some of these hernia repairs, which is really truly an interest of my practice. Along about the 2008, 2005, 2008, the Da Vinci robots came about, and there's a couple other robots that are now coming out of the market. What that really did was it overcame a lot of the limitations that we had with laparoscopic surgery because of the advancement. I'll show you some video in a little bit that'll kind of give you a little different perspective of what we're able to do laparoscopically. It's really kind of eye-opening. But it allowed us to overcome a lot of the limitations of the technology that we had available to be able to get a lot of these procedures done laparoscopically, to minimize tissue trauma, to lower the rate of infection, and to have better patient outcomes. So just to kind of again get back to my passion with hernias. Hernias are very common. About 1 million abdominal wall hernia repairs are done. Sorry about this, per year in the United States. It's probably underestimated how many truly hernias there are, because there's a lot of people that run around with hernias, I can tell you, that come into my practice for other reasons, and they're very, very common. I estimate about a third of the people will develop an umbilical hernia over their lifetime. And of men that are engaged in physical activity as part of their daily routine, probably somewhere between 20 and 30% of them will develop an inguinal hernia over their lifetime. I kind of alluded to previously with open traditional abdominal surgery, somewhere around 30%, 30 to 40% will develop an incisional hernia, and they can be very, very challenging to take care of. So kind of different types of hernias that there are. There really are three main types of hernias. There are congenital hernias, which people are obviously born with. Those can be at the belly button. They can be a diaphragmatic hernia, which is where part of the diaphragm doesn't fully develop. And you can actually have congenital groin hernias, where people have a failure of closure of where the blood supply to the testicle, as the testicle descends in males, for the abdominal wall to close up. And that could potentially lead to a hernia. And a hernia, by definition, is a tear or weakened area in the musculature of the abdominal wall. Acquired hernias, again, they're usually as a result of heavy lifting, straining. There are a variety of other reasons why people can get acquired hernias, and we'll talk about that in a second as well. And then I refer to incisional hernias, which usually refers to someone has had an incision which has violated the muscles of the abdominal wall at some point. It can be from a hysterectomy, cesarean section, appendectomy, prior hernia repair, a variety of procedures, and they all have the potential to lead to a hernia. Oops, go back here, sorry. So again, kind of a real simplistic form. A hernia is basically, again, a defect in the abdominal wall. So you can see on the left there, there's the squiggly lines are intestines. So your intestines are what we always get worried about, potentially poking out through a hernia. If that gets trapped, we refer to that as incarcerated. If that gets trapped and it compromises the blood supply to whatever pokes out through that hernia, that leads to a strangulation, which is a surgical emergency. Incarcerated hernias can be a surgical emergency as well, but strangulated hernias, if it chokes the blood supply off, it can make somebody sick, could potentially even kill you. So that's something we do not mess around with. Obviously, the goal of hernia surgery is to get everything back on the inside where it's supposed to be. And oftentimes that requires us to buttress the abdominal wall with a piece of mesh. Sometimes we can do primary repairs, which is where you basically sew the abdominal wall up with permanent sutures, but a majority of the time it does require some sort of reinforcement with some sort of artificial material, and most commonly that is referred to as mesh. Symptoms of hernia, most common symptoms are in the groin or abdominal area where people have pain. Pain and pressure at a hernia site. Sometimes it can be a very dull, aching pain. Sometimes it can be extremely severe pain to the point where people can barely walk or move around. They can also manifest not necessarily with pain, but just a gradual bulge in the abdominal or groin area. They are usually more prominent with standing, coughing, straining. Most of us have had a sports physical at some point in time where you stand up and the physician has you cough. They're trying to feel if there's unusual bulges or weakened areas in the abdominal wall that could potentially be a sign of an early hernia. And again, not all of them have to be symptomatic, but they can gradually get big over time. I usually equate hernias when I see people into the office where if they're not really having symptoms, it's like having a towel and making a bunch of shop rags out of it. Getting that seam started is tough, but once you get that seam started, it typically does get larger over time. And certainly if we can intervene before these become too big, and certainly before they become incarcerated or strangulated, we have a much lower incidence of recurrence and a much higher probability of being able to repair these on our terms, where we can use mesh or something to help to reinforce this, to help to get people back to work, to minimize the risk of recurrence and minimize the risks of complications as a result of ignoring these problems. Common reasons why people develop hernias, as I said, and these are more the acquired hernias, but they're frequent heavy lifting, so a lot of occupations going back to the construction, prior abdominal surgery. We know that scar tissue in the abdominal wall is only about 80% as strong as the native tissue. So any suture line you have, whether it's a mole that's removed on your skin, the muscle that's cut in your abdominal wall, it always is a potential weakened link. And so it's one of those things that we certainly pay attention to. And if people develop a bulge or kind of asymmetry of their abdominal wall after a surgery, certainly consideration of a hernia is something that we think about. Obesity, and anytime we are obese on the outside, we certainly have higher levels of intra-abdominal fat. They've actually done studies where they've measured the pressure inside of someone's abdomen when they're obese, and they actually have a higher resting pressure inside of their abdomen, which certainly causes additional forces on the abdominal wall. And if you have a weakened area, that certainly is a higher risk for causing that to gradually break down over time. We do know that some people just have weak connective tissue. Typically, it occurs in patients that are long-term smokers, but there are some connective tissue diseases that as people heal, they just don't form the same degree of scar tissue as other individuals do. Pregnancy, basically you have something inside your abdomen that is drastically increasing the intra-abdominal pressure, which makes small hernias sometimes manifest much more vigorously after pregnancy. And then things like coughing, simplest thing is coughing. Guys, as we get older, we can develop urinary retention from an enlarged prostate. All those things are transiently increasing the pressure inside of the abdominal cavity, which can cause breakdown or weakening of any potential weakened areas in the abdominal wall. Hernias are typically diagnosed, kind of the gold standard is physical exam. Most people, when they come to see me in the office, they do not necessarily have to have any abdominal imaging. It can, however, be confirmed with ultrasound, CAT scan, MRIs. Most of the time where I use some additional imaging studies are if I'm really questioning my physical exam. If we're worried about if people have had multiple prior surgeries, if they've had a prior old-fashioned mesh repair, and we're kind of wondering where mesh is, what's kind of going on, that's where I'll use imaging. But most of the time we can kind of forego that for a variety of reasons. Hopefully I can get into that a little bit more as we're talking about some of the laparoscopic approaches we use now for a majority of hernias. But really from a hernia management standpoint, extremely small hernias, if people are truly asymptomatic and there's a tiny hernia, and I assess that the risk of anything truly actually poking out, especially bowel poking out, they're not having any pain, there can be some degree of watching and waiting. I'm always cautious with patients, and obviously as a surgeon, you got to take this with a grain of salt, but if patients ignore these things because they just don't want to have surgery, we don't want them to come back when they're in extremis either. So we want to make sure that they understand the signs of things to watch out for, and they certainly have a lower rate of recurrence and a higher rate of success of us repairing these hernias when we can repair these on our terms. Certainly some of this, if patients aren't candidates for surgical intervention, they can limit their activity, light duty. We have some people that just don't have vacation time. We hear this fairly frequently. I can't take time off. I don't have any vacation time. So we try and limit their activity in the interval till we can kind of figure out the timing of getting these things fixed. I've had some people that have had just, so many hernia repairs done by providers over years that they actually have to change their occupation. They can't do construction anymore. They need to figure out what else they can do to try and make a living, but they just can't continue to put the strain on their abdominal wall. Very rarely do we recommend wearing a truss or what's called a hernia belt. You can get them on Amazon. We have people that come in the office all the time with these things on. It really isn't a fix. It's more just to kind of give some support to the abdominal wall, and it's a kind of a false sense that this is really making this thing better. It's just, again, supporting the abdominal wall in some way. We will sometimes, if people have them, I tell them it's no problem if they want to put it on after hernia repair just to give themselves a little bit of support or an abdominal binder, but it really doesn't have any effect on or any impact on the risk for recurrence. It's more for their psychological comfort than anything else. In the majority of hernias, we do recommend surgery. And again, the sooner we can intervene with most of these, the less complex and hopefully the faster their recovery becomes. Surgery, we talked about, and we'll talk about a couple of slides here. Traditional open surgery, the indications for that and the risks and benefits. Minimally invasive surgery, which includes laparoscopic surgery, but more traditionally, if you ask most general surgeons now, they're really referring to robotic-assisted surgery for repairing these hernias. Open hernia repairs usually, again, are traditionally done through a larger incision. It doesn't all have to be large incisions. A lot of umbilical hernias, if they're fairly small, we try and do a repair where we're not actually truly getting into the abdominal cavity, but doing the repair underneath the abdominal wall, which requires some sort of incision. The trade-off with this is that, if people have had multiple previous abdominal surgeries, they certainly can be more challenging as far as addressing hernias because of intra-abdominal scar tissue that limits your ability to see laparoscopically. Small hernias, my justification for repairing most umbilical hernias open is that I can make your belly button look more normal just by doing it through a periumbilical or around the belly button incision. But I'm also not, if I do have to use a piece of mesh, I'm not actually placing the mesh inside of the abdominal cavity. So we can actually create a space that's outside the abdominal cavity, but underneath the muscle to place that mesh kind of in a novel plane. And it's some principles we've used for some of our laparoscopic procedures as well that helps to minimize the risk for recurrence by using a mesh, but it also helps to minimize the risk of forming adhesions intra-abdominally. That isn't always the case, and most open hernia repairs that are done by placing a mesh truly inside of the abdominal cavity, which certainly has some risks associated with it. Recurrence rates really are similar with laparoscopic and open approaches. If you don't use mesh, I tell most patients they have about a 50-50 chance of having a recurrent hernia, except for extremely small umbilical hernias. Some of the risks associated with open hernia repairs: there is a higher documented risk for infection. We certainly know that if you make an incision over the top of where you're placing any sort of artificial material, there is a higher risk for infection just because of potential exposure. If that wound opens up, if it leaks, anything else like that, you could potentially get bacteria from your skin that gets down to the mesh level, and that could be an issue. The risk for infections is in the 1 to 3%, so it's a fairly small risk, but it's even smaller laparoscopically. We do have to do open repairs. Usually we have to really fixate the mesh some way, and that usually involves sewing the mesh through and through the muscle of the abdominal wall. And so as a result of that, what ends up happening is you have higher rate of pain. Most patients, because they have sutures go through and through the abdominal wall, as they move, those sutures don't have any play, they don't have any give, and that causes people to have a little more discomfort. Increased risk for blood loss, wound-related problems. And you fail to identify, because you're working through an open incision, not really getting an idea of what the rest of the abdominal wall looks like, the potential for contralateral additional hernias or weakened areas in the abdominal wall that you can otherwise recognize via some of the other techniques. Laparoscopic repairs, again, usually involves 3-4 incisions. Those incisions are usually well away from where our primary hernia is. So we have to have room to see with the camera. We have to have room to be able to actually put instruments in to work underneath the abdominal wall. And so all these procedures are a general anesthesia. Patients do go all the way to sleep to do the procedure. We actually blow your belly up below. So one of the incisions we put in is so we can actually blow sterile carbon dioxide into the abdomen, and that allows us to be able to create a space to then do the hernia repair. Potential benefits: because we're not sewing through the muscles, there's a little bit decreased pain. There's faster recovery to average daily activity. And that means, hey, I'm going to go to Walmart. That doesn't mean I'm going to go back and lift 2x4s at the job site. Lower risk for infection, as we said, because we're not making an incision right over the top of where our mesh is placed. Less blood loss, decreased wound-related complications. Again, recurrence rates are about the same. Some of the issues we had with laparoscopic hernia repairs traditionally was a little bit more difficult as far as fixation of the mesh. And it's some of the things that we've overcome with our robotic procedures. Because of the limitations of traditional laparoscopic surgery, there were traditionally longer operative times. And again, such dense adhesions could potentially preclude our ability. And it really was the limitations, again, of the technology that we were able to take down adhesions to be able to really assess the abdominal wall. And it was because of the limitations of those instruments rather than truly and our ability to see laparoscopically. So robotic-assisted hernia repairs came around, and this is something that, again, I've really grasped and taken hold of, and a lot of people are, a lot of surgeons that have even done traditional surgery, open surgery for a long time, have really recognized the value of incorporating robotics into some complex hernias, or even some of our more simplistic hernias, for a variety of reasons we can talk about in a second. Most of the time when people refer to robotic surgery, the most common system that people are using is the Da Vinci system by Intuitive Surgical. Their latest, this is one of the older models, but it looks very similar. There's what's called the Da Vinci Xi, and it has a rotating tower. It has 4 arms, one of which holds a camera, but 3 instruments that we can work with. So the surgeon actually has an extra arm. We can actually grab a hold of tissue, hold it in place, lock that arm in place, and have 2 other arms to be able to work. And I have a video we'll show you in a little bit here. Again, some of the benefits: ability to address more complex hernias. Part of it's because of the increased laparoscopic visualization that we have robotically. We also have wristed instruments, which have really overcome some of the technical limitations of traditional laparoscopy. When I refer to most laparoscopy, it's analogous to kind of having splints on your elbows and holding your arms out in front of you. You can kind of turn your wrists and move your arms in and out, but you really don't have a lot of mobility with what you're able to do. because we have instruments that are wristed, we're actually able to have 540 degrees of rotation, so better than my own hands do. But the dexterity and the ability to do really fine movements in the abdomen that allows us to really complete a very fine dissection. It also allows us to place mesh in some novel planes. So as I referred to with an umbilical hernia, if I can place that mesh underneath the muscle but outside the belly cavity, that's kind of the ideal place, because I want to minimize the risk of potentially forming adhesions to mesh or some of the complications that could potentially result as a result of that. If we're able to create a space underneath the muscle of the abdominal wall because of our ability to do that fine dissection, we're able to minimize the risk of adhesions, get hernias repaired, place that mesh in that novel plane to minimize the risk for adhesions, and get the same or better outcomes. It also allows us to be able to take down adhesions so we can truly assess the abdominal wall. And it's not uncommon, even when patients come to see me in the office where they've had a CAT scan, an MRI, an ultrasound that said, oh yeah, they have a clear hernia here, that if they've had multiple previous belly surgeries, we're actually able to identify other hernias or other areas of potential weakening in their abdominal wall that we can repair at the same time to limit their risk for reoperation and also limit their downtime in the future. It's a novel approach for recurrent hernias because we're really working in an undisturbed tissue plane. So if somebody's made an incision from the outside, if we're working from underneath the abdominal wall, we're not running into scar tissue that's kind of fused or disrupted those layers of the abdominal wall. We've certainly seen, and most of us that have truly adopted robotics into our practice, we've seen the benefits of laparoscopic surgery. It's overcome a lot of the limitations of traditional laparoscopic surgery. Improved patient outcomes and patient satisfaction is through the roof. Robotic surgery, again, you can kind of see this is ventral hernia repair. So if somebody had a hernia around their belly button, you would make incisions way off laterally so we have enough room to be able to work. Down in the groin area, again, we have to have space so we can kind of triangulate. So the camera is usually in the center incision, and then the other two ports are for working ports, and sometimes there's a fourth port as well. What is robotic-assisted surgery? A lot of patients ask me this. Robotic surgery does not mean that we tell the robot to fix your hernia. Essentially what happens is we have a robotic system that has arms that are controlled by the surgeon at a console. So what we actually do is we make a small incision, we blow the belly up like with sterile carbon dioxide as we normally do for laparoscopy. We then place additional ports. We actually connect the ports to the robotic system, and the ports are basically little hollow tubes that we can slide instruments in and out of. And then the surgeon steps away with assistants that are at the bedside to exchange instruments. The surgeon steps away to a console to be able to control the arms and perform the procedure under direct visualization with the high definition camera. So surgeon console, again, it's a 3D high definition camera that we use for these, which is a system that's way, way better than the traditional laparoscopic system. The patient cart that's positioned there, and then there's additional visualization instrument or visualization towers for controlling cautery, which is what we use to control bleeding, and for our assistants, which are working at the bedside, to be able to see as they're exchanging instruments and watching the procedure, because they're an active participant in what we're doing during the procedure. So this is, let me see if I can get this to play here. This is some of the instruments that we're putting in here. Pardon the corny music, but this is the 15 millimeter port, so centimeter and a half. And the instruments that are going in, the thing that with the two dots on the top is actually a camera, and it's again 3D high definition camera. And the instruments, you'll be able to see how well we're able to do this. We can really manipulate the camera, and I control the camera the whole time with foot movements, and then you're able to again just do a degree of dissection that is just unsurpassed. There's actually videos on the internet if people are ever interested and bored on a weekend. You can actually they actually skewer a grape on a stick, and you're actually able to peel the skin off the grape without disturbing the grape. That's how fine of a dissection we can do with this robot. And again, it's a game changer from a surgical technique standpoint. just to kind of go into this and kind of come into our last part, occupational medicine and employer engagement. This is really where this has been an eye opener for me from a surgeon, where, you know, I've just kind of been the person that somebody comes to with a hernia, and I try and get it scheduled as quickly as possible. I understand what our role is in this, and especially with Independence Health, with Wood County, with the Toledo Clinic, we understand that employers need their employees back to work as quickly as possible. This is an expensive endeavor, from a days off work, from a cost, from an insurance standpoint. So how can we coordinate care with specialists, expedite their care, try and control costs for patients and their employers, and then get these patients back as quickly and safely as possible. And that's where the traditional or the laparoscopic and robotic techniques have really come into play. I think coordinating care is a really important part of this, linking occupational medicines to physicians and engaged specialists. So it doesn't do an employer any good to send their patient or their employee, to occupational medicine and then have no specialists that are able to get anybody in to see them to get them taken care of so that we can get them back to work. So Independence Health, Wood County have all tried to engage specialists so that we all understand how important this is, and to create an open door policy for patients. We've created things such as centralized scheduling. We've engaged in specialists with saying, hey, can you leave spaces open in your schedule so that if there is somebody that needs to come in, they can be seen timely, and then we can try and coordinate their care to get their hernia taken care of, or their hematoma, or whatever it is, so that they're back on the job site as quickly as possible. It expedites the arrangement for therapeutics, any imaging, anything else that's done. If we can engage health systems, if we can engage physicians, it's not seeing a provider, waiting a month to get their MRI done, waiting 3 months to get their surgery done. We can streamline this whole process to make sure that we can be efficient. And then combining healthcare resources for a high quality, low cost model that creates excellent patient outcomes with a cost conscious mind. I mean, we all understand how expensive healthcare is. And the more we can engage the high quality, low cost providers in Northwest Ohio or anywhere, the better it is for everyone. So, back one more second. So again, just to kind of look at this return to duty, and I'll hopefully can expand on this just a little bit, minimum invasive techniques such as robotic-assisted hernia repairs, they expedite return to regular duty, hopefully in an expedited fashion. It certainly is not instantaneous. It's very much dependent on the type of work that people do. But because we're not disturbing tissue by making incisions through good tissue, we're hopefully able to get people back to at least light duty, or back to other duties quicker. Certainly with more patient satisfaction, with less perioperative pain. Hopefully in doing so, we're limiting the employer's financial implications in terms of healthcare dollars and lost productivity. I really appreciate the opportunity to talk with everyone today. And if anybody has any questions, I'll be glad to answer anything at this point.